Up to 84% of postmenopausal women are going to experience this physiological shift that can make literally just sitting in a chair an agonizing experience.
Yeah, it's incredibly common.
But the crazy part is that more than half of those women will never even mention it to their doctor. They genuinely believe that severe pelvic pain is just, a mandatory tax on getting older.
It was just the staggering normalization of suffering. I mean, people just assume it's this inevitable side effect of aging that you have to quietly endure.
Right.
Rather than seeing it for what it is, which is a highly treatable mechanical breakdown of the body's systems.
Exactly. So welcome to the deep dive. Today we are digging into an extensive stack of clinical guidelines. We've got stuff from the British Menopause Society, the NHS, the American Urological Association, and a bunch of leading women's health clinics.
It's a really robust set of sources.
It is. And our mission for today's deep dive is to answer a very specific and honestly frequently overlooked question. Can vaginal atrophy actually cause chronic pelvic pain?
And it's a critical question, too, because the disconnect between what you experience as a patient and how the medical community has historically talked about this, well, the gap is just vast.
Yeah.
But that is finally starting to change, thankfully, beginning with the actual language we use.
Right, because looking through the historical data, there was this major turning point around 2014.
Yes, exactly.
Experts officially moved away from terms like vulvovaginal atrophy or atrophic vaginitis, and rebranded the whole condition as genitourinary syndrome of menopause, or GSM.
Yeah, GSM.
Which makes sense because if you understand the anatomy, that old terminology feels, dangerously narrow.
Oh, it absolutely was. I mean, vulvovaginal atrophy implies that the biological fallout is isolated strictly to the vagina.
Right, like a localized issue.
Exactly. But estrogen receptors aren't just sitting in the vaginal canal. They are densely packed throughout the vulva, the bladder, the urethra, and that entire complex web of pelvic floor musculature.
Wow, okay.
So GSM is a much more accurate, comprehensive diagnosis because it acknowledges that a postmenopausal drop in estrogen affects that entire interconnected system.
I like to think of the pelvic region as an ecosystem. If you completely remove a vital nutrient from the soil, the whole landscape changes. And in this case, that nutrient is estrogen.
That's a great way to put it.
And that drop is immense,
Okay.
right? The sources say menopause brings roughly a 95% reduction in estrogen.
Yeah, 95%.
Which is massive. If estrogen is essentially the cellular architect of the pelvic region, it's responsible for driving collagen synthesis, maintaining elasticity, ensuring blood flow, then removing 95% of it means the structural integrity doesn't just weaken, it actively collapses.
That is the exact physiological reality. Without estrogen acting as that architect, the vaginal mucosa, the cellular lining, undergoes these profound changes.
Right.
It becomes visibly thinner, it loses its moisture-retaining capabilities, and it sacrifices its elasticity. The clinical literature actually notes that the vaginal canal itself shortens and narrows in response to this deficit.
It actually shrinks.
Yes, physically shortens and narrows.
Oh, wow. That structural change explains so much. I mean, if the canal is physically changing shape like that, it completely recontextualizes why standard gynecological exams suddenly become excruciating for so many older women.
Exactly. The architecture simply cannot accommodate what it used to.
Right.
And clinically, doctors actually look for specific visual markers of this structural breakdown. They look for the loss of a vaginal rugae.
Rugae.
Yeah, they're the natural accordion-like mucosal folds in the vaginal wall that allow for biomechanical expansion.
Oh, okay, like pleats in a skirt.
Precisely. And without estrogen, those folds flatten out entirely. You also see resorption of the labia mora, meaning the inner lips of the vulva actively recede.
I want to dig into the cellular mechanics of this for a second because we hear the term vaginal dryness thrown around constantly, right? Like in pharmaceutical commercials.
Oh, all the time.
And it's pitched almost like this minor nuisance you can just fix with some lotion. But looking at the clinical reality here, calling this dryness feels like a profound understatement.
It is a massive oversimplification.
Yeah.
I mean, we aren't just talking about a lack of surface moisture. We're talking about a hypoestrogenic state that completely alters the localized microbiome.
How so?
Well, let's look at the vaginal pH, for example.
Yep.
In a healthy, estrogen-rich environment, vaginal epithelial cells produce a carbohydrate called glycogen.
Okay.
And the protective bacteria in the vagina, specifically Lactobacilla, feed on that glycogen and produce lactic acid as a byproduct.
Which keeps the environment acidic, right, acting as an evolutionary defense mechanism against opportunistic infections.
Exactly. So when estrogen plummets, glycogen production halts. The lactobacilli literally starve and die off.
Oh, wow.
Yeah, and without that lactic acid, the vaginal pH rises, becoming far more alkaline. And this lack of acidity allows inflammatory bacteria to thrive. So the tissue isn't just dry.
It's sick.
Yes, it is actively inflamed, chemically compromised, and highly vulnerable to damage.
And that vulnerability leads to literal structural failure. The guidelines mention the development of petechia and fissures.
Right.
If I'm understanding the mechanism correctly, because the estrogen-deprived tissue loses its dense collagen scaffolding, the tiny subepithelial blood vessels, the capillaries right beneath the skin, become incredibly friable.
Highly friable, yes.
So the slightest movement causes them to burst, creating those tiny pinpoint blood spots, the petechia.
That's exactly how it works. The capillaries lose their structural support.
Yeah.
And goes further. The tissue becomes so delicate that everyday friction can cause micro tears or fissures in the mucosa.
So if that baseline state is already characterized by friability and chronic inflammation, introducing intense mechanical friction is going to be disastrous.
Exactly.
Which brings us to the reality of intimacy under these conditions.
Yeah, and this is where we see the clinical onset of dyspareunia, which is the medical term for painful sex. And GSM is unique because it can trigger multiple types of this pain.
Okay, break that down for us.
So there is superficial dyspareunia, which is severe burning and tearing right at the entry, the introitus. But GSM can also cause deep dyspareunia, where the pain is felt much higher up in the pelvis during deeper penetration.
Because the tissue lacks that natural blood flow-driven transudate, the lubrication, and has lost its biomechanical elasticity, we aren't just talking about discomfort, we are talking about literal mechanical trauma.
Yes.
Physical tearing of the vaginal opening and postcoital bleeding.
It's trauma.
Yeah.
And that mechanical trauma triggers a devastating neurological and psychological loop. I mean, repeatedly experiencing acute pain during intimacy understandably conditions the nervous system to expect pain.
Right.
You know it's going to hurt, so the brain initiates a threat response. That fear leads to the avoidance of sexual activity or intense anxiety when even attempting it.
And autonomic arousal is completely shut down by anxiety, isn't it?
No, completely.
If the body is in a state of sympathetic fight or flight because it expects pain, it just turns off the parasympathetic rest and digest systems that drive sexual arousal.
Exactly.
So you get zero natural lubrication, which just guarantees more friction, more tearing, and worsens the underlying tissue damage.
It is a self-perpetuating cycle of trauma. The brain and the body are communicating flawlessly, actually, but the message being sent is entirely based on threat prevention. The body is essentially trying to protect you from injury.
It's like accidentally touching a hot stove.
Yes.
Your brain wires your reflexes to flinch the next time you even get near the heat source to prevent another burn. It's a brilliant evolutionary survival mechanism, but here it accidentally creates a brand new problem.
That mechanism is central to understanding the bigger picture. When we ask, what exactly does flinching look like in the pelvis? We find the core answer to the central mission of our deep dive.
Right, like how does localized friction pain that specifically happens during intercourse, evolve into a chronic 204/7 pelvic pain syndrome?
Exactly. And it all comes down to the levator ani and the surrounding musculature. The clinical terminology for this is pelvic floor muscle overactivity, though you'll also hear it called a hypertonic pelvic floor or a non-relaxing pelvic floor.
So because the vaginal tissue is constantly irritated, maybe it's burning just from the friction of walking or wearing denim or experiencing acute tearing during intimacy, the pelvic floor muscles involuntarily tense up to protect the area.
Yes, they form a rigid protective muscular shield around the inflamed mucosal tissue.
It's the physiological equivalent of clenching your jaw when you have a severe toothache.
That's a perfect analogy. But consider the cellular level of a muscle that never unclenches. Over time, because the underlying trigger, the estrogen deprivation, isn't treated, those muscles remain in a state of sustained contraction.
You just stay locked.
They literally lose the neurological ability to relax. And a muscle in constant spasm burns through its oxygen supply rapidly, entering a state of hypoxia. Lactic acid builds up. Yeah, this unyielding tension creates dense, painful nodules in the muscle fibers, known as myofascial trigger points.
So suddenly the pain is no longer confined to moments of intimacy. The muscles themselves are screaming.
Right.
You have chronic, radiating pelvic pain that flares up while you're doing absolutely nothing out of the ordinary, just sitting down at your desk or driving a car.
And the guidelines draw a direct line between this mechanism and severe chronic pain conditions. They highlight vulvodynia, which is defined as chronic vulvar pain lasting more than 3 months without an identifiable active infection.
Wow.
They also point to provoked vestibulodynia, where the nerve endings at the vaginal opening become so hypersensitive that even the lightest touch, like just applying a topical cream, triggers severe searing pain.
They also detail vaginismus, right, where the hypertonic muscles involuntarily spasm so violently that the vaginal opening acts like a physical barrier.
Yes, exactly.
So attempting to use a tampon or undergo a routine cervical screening becomes biomechanically impossible.
That is the ultimate manifestation of the body's protective guarding response. The muscles lock the doors to prevent any further tissue damage.
Okay, I want to synthesize something here because looking at the broader effects of menopause, there's a paradox that trips a lot of people up.
Okay.
The clinical data also clearly states that the drop in estrogen causes the pelvic floor muscles to weaken. The loss of collagen causes the supporting ligaments to sag, which leads to pelvic organ prolapse, like the physical descent of the bladder or uterus.
Right.
So how do we reconcile this? How can a muscle group be structurally weak and sagging while simultaneously being so incredibly tense, rigid, and overactive that it causes chronic pain syndromes?
It's a brilliant question, and it is a fascinating paradox of dysfunction. Let's look at the two distinct support systems in the pelvis. You have the passive support, the ligaments and connective tissues, and the active support, the muscles.
Okay, passive and active.
Right. When estrogen drops, the passive collagen-based ligaments lose their tensile strength. They stretch out and fail.
So the organs start bearing down.
Yes. Yeah. And because the passive support has failed, the active support, the pelvic floor muscles, have to work overtime just to hold the organs up against gravity.
Oh, I see.
Add to that the nervous system's command to constantly clench to protect the burning vaginal tissue. What you end up with is a muscle that has lost its own underlying mass and elasticity, but is being forced by the brain to stay in a state of rigid, exhausted, hypoxic spasm.
It's essentially a frayed, degraded rope that is being pulled to its absolute maximum tension. It possesses no healthy functional strength, but it is completely rigid.
That perfectly captures the biomechanics of a hypertonic pelvic floor. It is weakness masquerading as tension.
Well, if the entire pelvic floor is locked in a state of inflamed hypoxic spasm, that tension can't just exist in a vacuum, right? It has to be pressing on everything else in the pelvic cavity.
Oh, absolutely.
Which explains why the urinary tract gets dragged into this cascade of dysfunction. I mean, I like to think of the pelvis like an apartment building with really thin walls. If the vagina is throwing a noisy, inflammatory party, the bladder next door is going to feel the vibrations and start acting up too.
That is a very accurate way to visualize it. The pelvic organs share a very crowded anatomical and neurological neighborhood. And returning to the concept of GSM genitourinary syndrome of menopause, the urinary aspect is just as profound as the genital aspect.
Right.
The bladder, the urethra, and the trigono, which is the smooth muscle base of the bladder, are absolutely packed with estrogen receptors.
So when the estrogen architect leaves the building, the urinary tract degrades right alongside the vaginal tissue.
It does. The urethra actually undergoes visible atrophy. The mucosal lining and the smooth muscle layer thin out drastically.
What?
And without that healthy, plump mucosal seal, the urethra can't stay fully closed, and it becomes incredibly susceptible to irritation. This leads to an avalanche of lower urinary tract symptoms: severe urinary frequency, sudden, uncontrollable urgency, and dysuria, which is a burning pain during urination.
The data also shows a dramatically higher risk of recurrent UTIs because, if the vaginal pH has become alkaline and those inflammatory bacteria have taken over, it's only a microscopic leap for those bacteria to travel up the shortened, compromised urethra into the bladder.
Exactly. The localized microbiome defense is completely down. But even more insidious is how the muscle spasms themselves mimic bladder infections through a mechanism called cross-organ sensitization.
Okay, let's unpack cross-organ sensitization. How does that work neurologically?
So the nerves supplying the distal third of the vagina and the nerves supplying the bladder and urethra share pathways in the sacral spinal cord.
Okay, they use the same highway.
Right. When the vaginal nerves and the hypertonic pelvic floor muscles are constantly firing high alert danger signals, The spinal cord gets incredibly noisy. The central nervous system essentially gets confused about where the pain is actually coming from, and it projects that pain onto the adjacent organ.
So the brain misinterprets a vaginal or muscular distress signal as a bladder distress signal. The patient experiences a heavy, aching, burning pelvic pain that feels exactly like a severe, acute bladder infection.
Yes, this is why so many postmenopausal women are continually diagnosed with bladder pain syndrome or interstitial cystitis. They go to the clinic in agony, convinced they have a raging UTI. The doctor runs a urine culture, and it comes back completely clear of bacteria.
Wait, really? The bladder is fine?
The bladder itself might be perfectly healthy.
That has to be maddening. You're told the tests are clear, maybe handed some over-the-counter painkillers and sent home, while the underlying root cause, the estrogen deprivation causing hypertonic muscles, is completely ignored.
It's devastating for the patients.
The American Urological Association data highlights a sobering reality. Over 60% of women have at least one symptom of poor pelvic floor health, yet they are constantly subjected to misdiagnoses.
It reveals a systemic failure in how we screen for and treat pelvic pain.
Hmm.
If clinicians only look at the organ that seems to be hurting the bladder, they entirely miss the true underlying mechanical failure in the vaginal ecosystem.
Okay, so we've thoroughly established the pathology. Vaginal atrophy absolutely causes chronic pelvic pain through a cascading domino effect of tissue degradation, neurological fear responses, and hypoxic muscle spasms.
Yes.
But the crucial part of these clinical guidelines is the protocol for recovery. Because this is a defined mechanical and hormonal failure, the medical community actually has highly effective, evidence-based interventions to reverse it, right?
Yes, thankfully. The most critical first-line intervention is addressing the root deficiency with localized hormone therapy, specifically vaginally applied estrogen.
So we're talking about low-dose creams, vaginal tablets, or flexible estrogen rings that are placed directly into the tissue.
Correct. And the consensus across all these guidelines, from the British Menopause Society to the Urological Associations, is that this treatment is both highly effective and remarkably safe.
Because it's local.
Exactly, because it is administered locally at a very low dose. An almost negligible amount enters the systemic bloodstream.
Ah.
It doesn't carry the broader systemic risks associated with older, high-dose oral hormone replacement therapies.
So it stays right there in the pelvic neighborhood, acting as a direct restorative agent.
Yes.
It encourages the cellular layers of the vaginal epithelium to thicken. It restores the glycogen production, which brings back the lactobacilli, dropping the pH back to its healthy acidic state. The tissue regains its stretch, and the friability, that tendency to tear and bleed, is radically reduced.
It's incredibly effective.
Oh.
But there is a crucial caveat here regarding systemic HRT that we have to mention.
Oh.
Many people assume that if a patient is already wearing an estrogen patch or taking an oral pill to manage hot flashes or bone density, their pelvic tissue is automatically protected.
Right, the logic being that if estrogen is in the bloodstream, it reaches everywhere.
It seems logical, but the clinical reality is different. The guidelines explicitly warn that women on systemic HRT frequently still experience advanced GSM.
Really? Even on the patch?
Even on the patch. The systemic dose required to eliminate a hot flash is rarely high enough to adequately saturate that dense network of estrogen receptors in the pelvic floor. Consequently, many patients require vaginally delivered estrogen concurrent with their systemic therapy to genuinely heal the localized tissue.
Wow. That distinction alone could save so many people from years of unaddressed pain.
Yeah.
So, step one is clearly to restore the architectural integrity of the mucosa with local estrogen.
Yes.
But what about the levator ani muscles? If they've been locked in a hypoxic spasm for 2 years, simply moisturizing the tissue above them isn't going to break the neurological habit of clenching, is it?
You're exactly right. Healing the burn on the hand doesn't stop the brain's instinct to flinch at the stove. This is where specialized myofascial pelvic floor physiotherapy becomes indispensable.
Ah.
And the clinical data backs this up. Beautifully supervised pelvic floor rehabilitation resolves these chronic pain symptoms in up to 74% of cases.
That's huge. And I think it is vital to clarify what this physiotherapy actually entails. Because when the general public hears pelvic floor exercises, the immediate assumption is Kegels.
Which is the absolute worst thing a patient with a hypertonic pelvic floor could do.
Really? The worst?
Oh, absolutely. A Kegel is an active concentric contraction of the muscle. If the muscle is already locked in an exhausted, painful spasm, actively forcing it to clench harder is akin to doing heavy bicep curls when your arm is already locked in the severe tearing cramp.
Yikes.
It will only generate more lactic acid, more hypoxia, and more pain.
So the objective isn't strengthening, it's neuromuscular re-education.
Exactly.
These physiotherapists utilize manual therapy like literally working internally to physically locate and release those dense myofascial trigger points in the muscle fibers.
Yes. They also utilize biofeedback devices, which are incredible tools for this specific pathology. Sensors are placed on the pelvic floor muscles, and they display the muscle's electrical activity on a screen.
Oh, so you can see it.
Right. The patient can visually see that their baseline state is this tense, jagged line. And through guided breathing and visualization, they actively learn how to consciously drop that tension and bring the line back down to zero.
That's fascinating. The guidelines also detail the use of the perfect scheme during these assessments, right? Evaluating power, endurance, repetitions, and fast contractions.
Yes, the perfect scheme.
Evaluating the fast contractions makes total sense to me because you need those fast twitch muscle fibers to fire instantly when you sneeze or cough to prevent stress incontinence, but they have to be able to immediately relax afterward.
Exactly. It's about restoring dynamic coordination, not just static strength. And alongside the physical therapy, the guidelines strongly support the use of adjunctive at-home tools.
Like what?
Vaginal dilators are used to gently and incrementally stretch the mucosal tissues, helping the nervous system acclimate to penetration without triggering that threat response. High-quality water-based lubricants prevent mechanical friction during intimacy, and non-hormonal vaginal moisturizers, typically containing hyaluronic acid, help maintain daily cellular hydration.
So it is a fundamentally multimodal approach. You use the localized estrogen to rebuild the structural integrity of the tissue, and you utilize specialized physiotherapy to retrain the nervous system and the musculature to finally let go of the threat response.
It is a comprehensive blueprint for reclaiming a patient's quality of life. But as we look toward the future of treating chronic pelvic pain, there is one final neurological adaptation that I think is crucial to consider.
Okay, what's up?
We've discussed how the nervous system reacts to acute pain by spasming the muscles. But over years of untreated GSM, the nervous system undergoes a deeper, more permanent shift.
Are you talking about the neuroplasticity of chronic pain?
Exactly. When pain signals constantly bombard the central nervous system over a period of years, the brain and spinal cord actually physically rewire themselves to become hyper-efficient at processing pain. This creates a state known as central sensitization.
Sensitization.
Right. The nerve pathways become so hyperreactive that the threshold for what constitutes pain drops dramatically.
Meaning that eventually, even non-painful stimuli like just the pressure of a waistband or the light touch of a cotton swab are misinterpreted by the brain as severe, dangerous pain.
Precisely. And the implication of central sensitization is profound. It means that even after you entirely heal the vaginal tissue with local estrogen, and even after you successfully release the muscular trigger points with physiotherapy, your brain might still project pain into the pelvis simply out of ingrained neurological habit.
Wow. The physical alarm system has been dismantled, but the brain keeps hallucinating the siren because it's just so accustomed to the noise.
That's exactly it.
It forces us to ask, as medical science advances, how much of treating long-term chronic pelvic pain won't just be about healing the local tissue or the muscle, but about finding targeted ways to neurologically reprogram the brain's ingrained memory of the pain itself.
It really highlights just how vital early intervention truly is. You have to treat the tissue before the brain has a chance to memorize the trauma.
That is a powerful paradigm shift. You don't just have to repair the structural damage, you have to convince the central nervous system that the environment is finally safe again. And I think that is an incredible place to wrap up today's deep dive. So until next time, keep questioning the mechanics of the body, keep exploring the science, and remember, severe pain is never just a mandatory tax on getting older. Take care of yourselves.